Hey, good afternoon, everybody. I hope you're doing well. Welcome to this Tobacco Control Data Initiative webinar entitled New Evidence on Tobacco and Nicotine Use in South Africa, Findings from the TCDI Spot Check Survey. So TCDI, whenever I refer to it during this webinar, is referring to the Tobacco Control Data Initiative. My name is Thomas van Huyssteen, and I'm the country lead for the South African team of the TCDI project, and I'll be moderating the session. Just for time's sake and to ensure there's time for questions at the end, I'm going to start the presentations as of now. So just before getting started, a little bit of an outline of what we will be doing today. So we'll start with a 5-minute introduction by myself, and I'll briefly introduce the Tobacco Control Data Initiative, talk briefly about what the survey that we are highlighting today was, and then I'll introduce the speakers. I'll then hand over to the speakers for 3 presentations. The first will be a relatively short presentation on the spot check survey methodology. We will then have a presentation on the quantitative findings and 1 presentation on the qualitative findings. We expect this to take about 45 to 50 minutes so that there'll be 10 to 15 minutes for discussions and questions at the end. Should you have any questions, please feel free to pose them in the chat as we are going. I'll collect those questions and pose them to the speakers at the end of the session. Again, to those that have just joined, I'd like to extend a special welcome to our South African core stakeholder group and members of the South African National Department of Health, as well as those of the provincial departments of health. Thank you very much for attending this important webinar today. So just a little bit of introduction to the Tobacco Control Data Initiative for those that do not know what it is. What we do is provide an interactive portal which collects, analyzes, and presents data and information on tobacco control through primary, rigorous, and secondary research. As of now, we operate in 6 African countries, which are the Democratic Republic of Congo, Ethiopia, Kenya, Nigeria, South Africa, and Zambia, and we will be adding the 7th country in this year, which will be Senegal. On some of my slides, you'll see there are QR codes, and those QR codes can be scanned to take you to the particular websites which I am mentioning. The South Africa dashboard, which you can access via the QR code here, has data and information related to 8 tobacco control themes at this point. The first is tobacco prevalence. We have data on illicit trade, the health burden of nicotine and tobacco products, tobacco taxation, enforcement, tobacco industry interference, new and emerging nicotine and tobacco products, and tobacco agriculture. You can have a look at the dashboard and explore the themes in your own time. So as I said, what we're doing today is presenting some data, and this is from some of the primary research which we have conducted, and this was a survey which we called the TCDI Prevalence Spot Check Survey. And what this was a rapid policy-orientated data collection effort designed to generate timely insights into tobacco and nicotine use in South Africa. And we combined both quantitative data on prevalence, patterns of use, and associated factors with qualitative insights into the behaviors, perceptions, and emerging trends related to tobacco and nicotine products. We collected data in 2 provinces, which were KwaZulu-Natal and the Western Cape, which provides a focused but robust snapshot of the current use dynamics in these 2 provinces. So although this is not a nationally representative study, the survey was designed to complement existing data sources by offering more up-to-date context-specific evidence to inform policy, planning, and public health responses. So as the Tobacco Control Data Initiative, we led this project, but the implementing partner on the ground in South Africa, which did the data collection and analysis, was the Moses Kotane Research Institute, and we'll have members of the organization speaking today. So here are the speakers for today. I've already introduced myself. I'm Thomas van Huyssteen, the country lead of the South Africa team of the Tobacco Control Data Initiative. Our first presentation will then be from Dr. Terefe Gelibo, who is the research lead for the entire multi-country tobacco control data initiative and a postdoctoral researcher at the University of Ottawa Heart Institute, and he'll present the spot check survey methodology. We'll then hand over to 2 presentations from people representing the Moses Kotane Research Institute. The first will be a presentation by Senzo Mthembu on the quantitative findings, and he is a lecturer in the Health Economics Unit at the School of Public Health at the University of Cape Town. The final presentation will be from Dr. Velenkosini Matsebula, the Director of the African Center for Development Finance and Senior Lecturer at Stellenbosch Business School, and he'll be presenting the qualitative findings. So without further ado, we will begin the webinar, and I will hand over to Dr. Terefe Gelibo to talk about the spot check survey methodology. Terefe, over to you.
Thank you, Thomas. So cognizant of the fact that we saw the data gap across the 6 TCDI implementing countries, and we designed a sentinel kind of survey, the spot check prevalence survey. Next slide, please. So the objective of this survey is just to assess the prevalence across the 3 countries by selecting key provinces across the countries. And we also wanted to estimate the prevalence of the tobacco and nicotine product use across these countries, and also try to see the factors that are associated with the use of these tobacco and nicotine products. And we also complemented some explorative ways of looking to the perceptions around the use of tobacco and nicotine product, as well as we wanted also to see the use of the cessation services across the country. So designing this survey across the TCDI countries, we prioritized the 3 countries, DRC, South Africa, and Zambia in this first round. Next slide, please. So the methodological overview is that mainly we have adapted the global adult tobacco survey methodology in general, with few contextualization to the country context, as well as an addition of some qualitative component. So our survey design is mainly a mixed method comprising the quantitative as well as the qualitative. And the scope of this survey is not a national presentation. Rather, it's like provisional representation considering a prevalence gradient across the countries using data set from the available surveys. For example, in DRC, we have selected 2, one high prevalent and one low prevalent, which is Notuwangi was selected as a high prevalent, and Hotlumami was selected as a low prevalence based on the available evidence, such as the multiple indicator cluster survey findings. The same is true in South Africa, where we have selected the Western Cape as a high prevalent and KZN as a low prevalent based on the GATS 2021 dataset. And also in Zambia, Lapula and Southern Province were selected as appropriate. So accordingly, we had like a sampling frame. Considering for the qualitative, we designed to have at least 12 FGDs and 20 key informant interviews. And for the quantitative, using the standard methodologies for sample size calculation, we have about 1,400 in DRC, to 2,500 in South Africa, and also 2,100 in Zambia in general has been considered for this survey. Next slide, please. So the sampling design for this survey is a multi-stage probabilistic sampling, considering the selection of enumeration areas, selection of households, and selection of eligible individuals following the 3 stage. And the first stage of selection of enumeration area was made in collaboration with the people in each country's Bureau of Statistics team. But the second stage was based on the household listing operation we have conducted. And then based on that selection, we have made a selection of individuals using Kish method. And for the qualitative, it's mainly purposive. And for the 20 KIs, we try to represent people from Ministry of Health down to the provinces and community. And for the FGDs, mainly disaggregated by urban, rural, use, male, female. Disaggregation has been made across the countries, and the main participants were community members and participants of the survey. Next slide. So mainly the data collection activities for the quantitative and the qualitative, we had separate team members. And for the quantitative, after having a regulatory approval across each country, we started with household listing operation and then interviewing the household heads for the household roster and household characteristics and interviewing of individuals on the 11 modules that we have designed, focusing on the specific tobacco product, the knowledge attitude, the smoking cessation, and the second-hand smoke-free components. And for the qualitative, we have the focus group discussion with the designated individuals that we have mentioned, specifically the participants in the community. And the key informant interviews were conducted from the Ministry of Health down to the civil society organizations, healthcare providers, as well as the provincial and district officials. Next slide. So the tobacco product included in this survey were like any tobacco and nicotine product, which comprises like the any tobacco product and any nicotine product. So when we say any tobacco product, we included the smokeless, the heated, and the smoked ones. And in the smoked ones, we also included the manufactured cigarettes, the hand rolled, the water pipe, and other smoker products. And in the nicotine, we only included the electronic cigarettes. So the prevalence estimates that we're going to present will include these products. So it can be overall or any tobacco specific product. Next slide, please. So the analysis done in this estimate were based on the survey weighting standard according to the national population-based survey procedures. So we have a base weight based on the first probabilities of selection, and based on the collected data, we also adjusted for non-response, and also we tried to adjust for the population deviances using the calibration adjustments, and finally we computed the final survey weight. So any estimate that we present is a representative of the provinces selected in this survey, considering all the stages of selection and ensuring the under and over coverage that has happened according to the survey design. Next slide, please. So for the qualitative, we used a theoretical framework from the designing of the tool to the analysis. And for this particular qualitative study, we used theory of planned behavior, considering the determinants of individual intentions to do or not to do a behavior based on their attitude towards the behavior, the subjective norm, and the perception. So considering this from the theoretical design to interpretation of the finding, our all findings were all trimmed around the theory of planned behavior with addition of few components that can address country-specific contexts. Next slide, please. Regarding the data transfer, monitoring, and cleaning across the countries, we followed a systematic approach of designing a unified electronic data management tool, which we used those survey CTO. So each country had that, and the data collected from the field were sent to the country designated server, and the country team reviewed the data in the actual basis, and they also tried to share the anonymized data with the DG team for further clarification as well as quality control procedures. Next slide. So in terms of data management and analysis for this survey, I'll just mainly focus for South Africa. So in the context of South Africa, our analysis in this report will comprise about 1,700 respondents reached, considering of different contexts in the field, data collection, the net responses, and the like. And we analyzed the data considering the population-based estimates, specifically the survey weight, which I mentioned was applied, and all our estimates were produced, disaggregated by the different dynamics or domains, specifically the age, gender, residence, and other socio-demographic informations. And also we try to fit a logistic regression model to identify the key factors associated with tobacco and nicotine use in South Africa. So for the qualitative, the content analysis has been made across all the countries, and the qualitative team will have details on the presentation. Next slide, please. So overall, like the research design that we implemented across the 3 countries is comprehensive enough to have a comparisons across the countries as well as within the high and the low gradient provinces. So this is not, like as I said, a national representative survey, rather it is a provincial representative survey that tried to see the gradient is from the low and the high prevalent areas, so that we're going to see the both extremities and the progress that has been made across the countries. Thank you. If you have any question, back to you, Thomas.
Thanks very much, Terefe. So that gives you some background to the method employed in both the quantitative and qualitative side of the survey. I'm now going to hand over to Senzo Mthembu to introduce the main quantitative findings. Over to you, Senzo.
All right, thank you so much, Thomas, and good afternoon to everybody. So this session will present the quantitative findings from the Spot Check Prevalence Survey, which was conducted in the Western Cape and the KwaZulu-Natal province. So I would largely focus on the key patterns in prevalence, the product use, behavior, and policy relevant insights. Next slide, Thomas. All right, so just a quick sample context. So the sample was predominantly urban with a balanced gender distribution and a concentration in the working age population, which was primarily those between the ages of 25 and 44. We also observed some clear socioeconomic differences between the 2 provinces. For the Western Cape sample, we noticed that it was more urban, much wealthier and more educated, while the KwaZulu-Natal province was more rural and concentrated in the lower wealth groups. So these contexts, the differences between the contexts are important because they shape the pattern of tobacco and the nicotine use. Next slide. All right, so one of the key findings was the prevalence of tobacco and nicotine use, where we found that the prevalence of any tobacco and nicotine use was high in both provinces. In the Western Cape, it is approximately 40.8%, while in the KwaZulu-Natal province, it was at 31.2. It is at 31.2%. So each of these estimates include a 95% confidence interval, which reflects the statistical uncertainty, while there is some overlap between the 2 estimates. So the pattern does suggest that there is some consistently higher prevalence in the Western Cape within the sampled population. And these highlight the substantial burden of tobacco and nicotine use across both settings. Next slide, Thomas. All right, so next we move on to the combustibles versus the non-combustibles. When we aggregated the product types, we noticed that the smoking remains the dominant form of use in provinces. And any tobacco use was around 34% in the Western Cape, as compared to the KwaZulu-Natal is 31%. So they still make up a vast majority of those that engaged in tobacco activities. And cigarette and roll-your-own products are the primary drivers of use. And this basically indicates that despite the emergence of the new products, the traditional combustible tobacco still remains quite the central public health concern. Next slide. All right. So if we observe the emerging products, we also see some quite interesting differences between those emerging products, such as in the Western Cape, we highlighted or noticed that the e-cigarette use was notably higher at around 12.73% compared to just under 2% in KwaZulu-Natal. We also saw that shisha use shows a similar pattern. And in contrast, if you look at the smokeless tobacco, it was more concentrated or more common in the KwaZulu-Natal province. So what this means is that at least the pattern suggests the product is product use is quite shaped by the local context of the two provinces, including urbanization, the socio-economic status, and the social norms, which the qualitative report is going to talk more about. Next slide. All right, so the slide you are seeing is in relation to the demographic patterns, looking at the demographic differences where we can see a clear pattern by sex and resident area as to where the person is situated. In KwaZulu-Natal, tobacco use is heavily concentrated amongst men with much lower prevalence amongst women, as you can see with the different statistics. And in the Western Cape province, the gender gap is smaller, so indicating a more widespread use across both men and women. And if you look at the rural, whether the person is in the urban or in the rural setting, so those which were situated in the rural populations, in this case, showed a higher prevalence than the urban populations for both provinces. And if we look at the age graph, we can see that use is predominantly high amongst young adults, especially if you look at the Western Cape province. And we notice that the emerging product tends to be more common amongst younger individuals. And I think in the next slide, that's when we break it down. Next slide, Thomas. All right, so this is okay, the age group. Basically, what we are showing here is that the younger adults show a higher uptake of emerging products such as your e-cigarettes and your shisha. This suggests that there is the newer nicotine products, which are predominantly appealing to younger populations, raising concerns about the future trend in nicotine dependence. Next slide. All right. The next part is the frequency and the intensity, where we also looked at how often do people smoke cigarettes, one of the most striking findings is that tobacco use is highly frequent, where the daily smoking dominates across all groups, with over 95% of smokers reporting daily use at least. And the daily smoking dominates amongst the cigarette users alone. You've got daily use is nearly universal in both provinces. And in terms of the intensity, cigarette use averages close to daily consumption around about 28 days per month. So this indicates that tobacco use is not an occasional or an experimental thing. It is actually entrenched and habitual. So it's something that people don't just leave it at the trying out, experimenting and stuff. Next slide. All right. Next, we analyze the age of initiation for both cigarettes and the newer products. It became quite clear that cigarette use begins very early, The average age of initiation is about 18 to 19 years old, with many young adults reporting starting as early as 15 and 16. We also did see in some cases where there were those that indicated that they actually started at the age of 12 years old. This suggests that initiation often occurs during school years. And in contrast, the newer products, such as now your e-cigarettes and your shishas, tend to be adopted in a much later stage, typically in the early to mid-20s. So the consistency of the early cigarette initiation across the age groups highlights the importance of prevention strategies, which is going to be targeted at the adolescents. Next slide. All right. So the next part that we were interested in is I think that's meant to be the cessation behavior. Well, I think the most encouraging part about these results is that about half of the smokers actually have reported that they have attempted to quit in the past, and more than a quarter have indicated an intention to quit. And the reasons behind this, they're motivated by personal health concerns, the social influences around them, and also the cost of tobacco and nicotine products. So, however, despite this intention, sustained cessation remains very limited, suggesting the gaps in the support system. And this is something which we also going to speak more about in the qualitative report. Next slide. All right, so the secondhand smoke exposure remains extremely high. And so while the indoor exposure is relatively low, we noticed that the exposure in outdoor public spaces was very high, exceeding more than 90% of those that report that in both provinces. So exposure in schools is particularly concerning. There was the big concerning one, reaching nearly universal levels at around 99%. So we have a lot of that happening in our schools, and these findings point to what we see as could be a weak enforcement of the enforcement of smoke-free policies or the continued exposure to public environments. Next slide. All right. But despite this is meant to be the awareness. So despite this, awareness of the harms of smoking is high in both provinces, with over 85% of respondents recognizing the health risk of smoking and the secondhand smoke. And however, exposure to anti-tobacco messaging, it varies, and awareness does not necessarily translate to behavior changes. And we see that we still have many of the respondents that indicate that they've been at least been informed or told by the health worker. And if you look at in the province of KwaZulu-Natal, you actually get to see the influences that radio still has in awareness in spreading these messages as compared to the Western Cape. And yeah, next slide. Right. Yeah, I think the heading is also incorrect there. It's supposed to be acceptability and commonness. So we also examined perceptions of acceptability and commonness. So if you look at the Western Cape, tobacco is perceived as more socially acceptable and common for both men and women. At least that's what our results found. And if you look at it, KwaZulu-Natal, perceived acceptability was much lower, particularly for women. And most importantly, these, just to highlight that these are perception measures. They reflect the social norms rather than the actual behavior. So these findings suggest that the social and the cultural context plays a critical role in shaping tobacco use. Next slide. All right. I think the key insight here is that, in summary, there are several key patterns that emerge from the results. One, we observe that there is a high prevalence. There's an early initiation, and there is which is strongly entrenched daily smoking behavior. Also, we found that the secondhand smoking exposure remains widespread, and there is a clear demand for cessation support. And together, these findings point to a persistent and complex public health challenge that we would need to address. So I think, next slide. Yeah, that should be all.
Thank you very much, Senzo, for that presentation. So that highlights some of the key quantitative findings which emanated from the Spot Check survey. I'll now hand over to our final presenter, Dr. Velenkosini Matsebula, who's going to report some of the key qualitative findings from the survey. Over to you.
All right. Thank you, Thomas. Can you please move to the next slide? All right. So from the qualitative component of the study, as indicated in the introduction by the first speaker, we used the focus group discussion and the key informant interview, which were structured around the theory of blend behavior as the framework for collecting this qualitative data. So the FDGs, or rather the focus group discussions, explored community knowledge, attitude, perceptions, and cultural norms regarding tobacco use and cessation behaviors, while the KIIs gathered detailed insight from stakeholders such as your healthcare providers, your policymakers, and tobacco control advocates, which basically these are the people focusing on policy change and barriers to effective tobacco control, as well as a recommendation for enhancing cessation as we move forward. Next slide, please, Thomas. All right. So the participation profile for the qualitative component was such that we had 66 FDG participants in total, and 20 key informant interviews or participants that were reached in the study. So in total, we had around 86 participants. Overall, this was divided between 48.8% being female as well as 51.2% being male. Whereas the mean of the age for overall it was around 30 years, and for the FDGs, the mean was around 27, while the KIIs was around 28. And how these FDGs were stratified, we looked at the adult males, adult females, young males, young females, and rural and urban settings. So this is how exactly we divided them. So we look at these different groups between the rural and urban settings. Next slide, please, Thomas. Yeah, so how we did it is that we covered two objectives. So the first objective looked at the knowledge, perception, and belief about tobacco use and cessation, whereas the second objective looked at the barriers to tobacco cessation services and support. So what we're going to do now, we're just going to look at some snapshot of the results for each. So we're starting first with the objective one. So from the knowledge, perception, and attitude towards tobacco, what we tend to see is that participants showed a clear awareness of tobacco dangers, but they seem to continue to frame it as a coping mechanism and emotional outlet. So basically, they looked at tobacco use as a coping mechanism and an emotional outlet or something to do for those aspects. So we looked at different themes within this broader theme of the knowledge, perception, and attitude towards tobacco use. So the first was the awareness of health risk. So participants demonstrated high awareness of tobacco harms, commonly linking these smoking behaviors to cancer, respiratory diseases, and premature death. Some of the quotations here seem to advocate that, for instance, a private hospital doctor in the urban of KwaZulu-Natal noted that the first thing that comes to their mind when they hear the word tobacco is lung cancer. This basically denotes that they are aware of the dangers that come with using tobacco products, and they also allude that they have lost family members through the use of tobacco products. And this was also advocated for by other public health participants or employees, who basically indicated that they always think of diseases when they think about tobacco. So the view across the gender and geographic areas confirms that the health awareness is widespread. Yet at the same time, participants later rationalized their behavior as stress relief or cultural practice. And I think some of these things we'll see as we move forward. Please move to the next slide, Thomas. All right. So the other theme under the greater under the knowledge, perception, and attitude towards tobacco, we also looked at the triggers for tobacco use. What exactly triggers people to use tobacco? So participants gave varying reasons for starting and resuming smoking in cases that where they've stopped. But mostly we would see that stress and peer influence, boredom, and social drinking emerge as consistent triggers for the consistent triggers for the use of tobacco. So the youth participants often frame smoking as an act of experimentation or rebellion, while adults cited economic and social stresses. So, for instance, a male youth respondent in KwaZulu-Natal noted that peer pressure, stress, and having nothing to do will be some of the things that lead them to smoke. While two female youth respondents from the rural Western Cape cited that peer pressure, stress, and experiencing new things. They also noted that in their community, they do not have a lot of activities. So smoking seems to be some of the things that they do to pass on time. So these triggers for use of tobacco sit at the intersection of emotional and the emotions and environment. So it mirrors the wider social realities of limited recreation, stress, and alcohol use, particularly among young men. Please move to the next slide, Thomas. So another theme looked at the perceived benefits and misconception. So despite recognizing tobacco harms, that there are harms that comes with tobacco use, many participants believe that smoking is sometimes viewed as something that would probably give you a psychological or cognitive benefit. So participants indicated that they believe it to be relaxing, intellectually stimulating, or therapeutical. And these are all of the myths that fit the habitual use of tobacco, while others indicated the use of tobacco having to make people smarter in their belief. So this is also supported by medical doctors from KZN that indicated that misconceptions, if the misconception that if smoking you will never stop, that if you try to quit smoking, it won't be easy because people never try to quit smoking. So this misconception that smoking reduces stress and makes people smarter basically is the reason that in most cases they find that makes people to start smoking or return to smoking behaviors. So across these themes, knowledge, attitude, and perception forms a layered narrative. So participants understand that tobacco is harmful, but also point to other deeming it necessary, which makes it a toxic and therapy outlet at the same time, at once. Yes, please move on, Thomas. All right, so the other theme, broader theme, look at the beliefs and norms towards tobacco. So this theme basically captures how social and cultural structures give tobacco meaning beyond individual choice. So beliefs around gender, heritage, and affordability reveal that tobacco is embedded in the system of identity and tradition. So for instance, if we look at the gender perception theme, so gender norms strongly shape how participants perceive smoking behavior. So men's smoking was largely accepted or even normalized throughout the study, while women's smoking was viewed as morally inappropriate. So there were stigmas that came with females that smoke. For instance, a male adult participants from urban KwaZulu-Natal cited that in most African communities, smoking is okay if you are a man, but frowned upon if you are a woman. And while an adult female participants from rural KZN supported this, indicating that parents always scolded teenagers, especially girls, of smoking, which indicate that there is that gender disbalance. So a male participant from the same province cemented this even further, stating that the belief that females should not smoke is a cultural belief, which means that there is some allowance for male smokers. And the double standards reinforces stigma, particularly against female smokers, discouraging them from seeking help or discussing their addiction openly because it is not widely accepted in that regard. Please move to the next slide, Thomas. Then when we look at the cultural belief and ritual use, cultural narrative position tobacco as a sacred or ancestral item. Participants across KwaZulu-Natal and parts of Western Cape describe tobacco as an offering, a bridge between the living and the spiritual world. So they sort of indicated that it links them to the other side or spiritual part of their beliefs. So culturally, tobacco are used in ritual reinforcement, and it's acceptable. And the misconceptions such as traditional tobacco is harmless and only cigarettes are harmful, affect cessation efforts negatively. So many residents falsely believe that smoking traditional or more homegrown tobacco products is safer than cigarettes from the store. So this is some of the quotations or the things that were said by a traditional rural leader in KwaZulu-Natal. So there are also cultural and social norms in some Black African communities. The use of tobacco, especially snuff, is part of the cultural practice, like communicating with ancestors. So, for instance, one participant was heard saying tobacco is banned during ceremonies, meaning that is part of the traditional practices that we see in our communities. So this cultural framing complicates the cessation discourse, as rejecting tobacco can, in some instances, appear as rejecting your identity. So sustainable interventions must therefore integrate, not confront traditional authorities. Please move to the next slide, Thomas. So still on the first objective, we also look at the theme that speaks to the product preference and affordability. So economic factors shape both the type and amount of tobacco consumed. So single sticks and cheap illicit brands are reported to dominate low-income settings, while vaping and hookah pipes are reported to signal modernity and better taste among the younger people or the youth. For instance, if we look at some of the quotes that we see there, a female responded from the rural Western Cape indicated that it's easily accessible because a cigarette is only 50 cents. So in other words, the economic factor shapes that smoking behavior because of the accessibility due to the price of that single stick use. So socially, people have created their own narrative around tobacco use that distorts the truth. So the tobacco industry has been very strategic itself in how it markets tobacco as part of a lifestyle and something that looks cool or harmless, especially when it comes to the modern ways of modern forms of tobacco, such as your vaping and hookahs. Please move to the next slide, Thomas. Then the broader theme looks at the community perception towards tobacco. So basically, this cluster explores how community collectively frame tobacco use through stigma, moral judgment, normalization, and other parts. So it reveals a contradiction where smokers are both condemned and excused. So, for instance, if we look at the sub-theme that looks at the social stigma and moral judgment, stigma surfaces as both social sanction and silencing force. So smokers and smoking were described as in some cases they were described as being irresponsible, less smart, or weak-willed, which discourage open disclosure or help seeking for those who are already hooked to those addictions. So, for instance, the quote from KwaZulu-Natal focus group discussion participants indicated that people do not like it because smokers smoke everywhere, even around children, and end up getting secondary smoke, and it smells. So, with another stating that smokers are believed to commit crime in their communities. So, there is also that stigma that is bestowed upon those people who smoke, and basically discourage their need to seek help. So such attitudes individualize blame, obscuring the social roots of addiction and deepening the exclusion, particularly for women and youth who are not largely accepted in the smoking culture. Please move to the next slide, Thomas. All right, so looking at the normalization and in the intergenerational influence. So at the same time, smoking was described as everywhere, integrated into daily routines and visible across generalization. So normalization reduced its perceived severity and normal weight. So it's basically something that in some cases you would see that this type of behaviors are considered as something that is normal and is being everywhere in some communities. For instance, in the Western Cape, a focus group discussion in the urban area, male participant was heard having to say, in our community, we generally just smoke cigarette and not hookah pipe, but it is very common. And another was heard saying, I think it is so normal that people do not see it as something wrong. So it is widely accepted. So at a community level, the moralism and normalization coexist, producing that inconsistency that undermines those cessation advocates. So without framing tobacco as a collective health challenge rather than an individual failure, stigma will continue to silence dialogue and normalize. Normalization will persevere and push the use of tobacco. Please move to the next slide, Thomas. Then moving on to the objective 2, which basically looked at the barriers to tobacco cessation services and support. The first broader theme looked at the service availability and system gaps. So this theme basically highlights the persistent shortcomings within the health system that hinder the tobacco cessation efforts. So participants described how limited services availability, lack of dedicated cessation programs, and resource constraints make quitting difficult even for individuals who are motivated to stop smoking. So while some health facilities may offer brief advice, comprehensive cessation support is rare and often inaccessible. So the sub-theme one of the sub-themes that we looked at here was the availability of cessation aid. So participants widely describe cessation aid as such as nicotine replacement therapies and medications as scarce, costly, and largely confined to private sector. While some awareness of these intervention exists, access is constrained by affordability, supply shortages, and the absence of public funding or inclusion in essential medicine list. So yeah, there are some quotes there that really support this, but for the sake of time, I I will try not to mostly repeat them. So, but while most of the participants emphasize the lack and cost of nicotine replacement therapies, some described an alternative philosophical stance towards cessation. Yeah, so a national tobacco control representative indicated that they consciously avoid promoting pharmaceutical aid, favoring natural recovery method instead. So there is that quite contradicting stance when it comes to those efforts. Please move to the next slide, Thomas. Then the other sub-theme that we looked at was the social, cultural, and economic constraints. So this theme basically illustrates how social context and poverty reinforce tobacco dependence. So even when individuals express their desire to quit, environmental and economic pressures sustain consumption. Smoking becomes not only a habit, but a mechanism for coping and belonging. So economic stress and unemployment are some of the things that were cited, and hence we put it there as a sub-theme. So participants constantly link smoking to financial strain, unemployment, and broader socioeconomic distress. So tobacco was described as both a source of income and a means of psychological relief for those facing economic hardships. So between these reflections, participants describe how financial distress, stress, and unemployment create a shared vulnerability across communities. While some pointed to women experiences of stress related to joblessness, others emphasized that economic instabilities in general drives both men and women to seek comfort in smoking. So there is that mix on how they believe really drives their smoking behavior. Please move to the next slide, Thomas.
Just for time's sake, Dr. Vele, I'm going to go to the last slide, recommendations.
All right, no, yeah, let's do that. We can do that. So some of the recommendations that we really pointed out from the study is that there is we need to strengthen community-based cessation programs by integrating tobacco control into existing primary healthcare services and training healthcare professionals in cessation techniques, as we see some missing gaps there. There's also a need to enhance awareness campaigns using local language and media platforms popular amongst youth and rural dwellers, so that the message really reaches the people that are mostly in need of these services. And yeah, I think, yes, these are some of the broader recommendations, but collectively, these steps aim to bridge the gap between policy and lived experiences and ensure that the cessation interventions are both contextually relevant and equitably delivered. So there is a need to make sure that our effort basically reaches the people that need it the most. Thank you, Thomas. I think I will end it there.
Thank you very much, Dr. Vele, for that presentation. I'm just going to briefly hand over to Dr. Ko from the Office of the CEO of the Moses Kotane Research Institute to just briefly talk for about a minute. The floor is yours.
Thank you very much, colleagues. The Dr. Konjelwayo from the Office of the CEO, Moses Kotane Research Institute. The address that really comes from our office is an appreciation regarding the study and with specific connections with the various systems that affect, one, the pharmaceutical space, number two, the policy space and the policy and legislative framework, economy and socio-economic policies, economic growth and all that. We were privileged really to be part of this study, and we look forward to more studies of the same nature that really seeks to create relevance in what really is going on in the community. So on behalf of the CEO, we are very appreciative of this platform. We also appreciating the fact that we could be part of this study, and we look forward to more collaborative work that would, in actual fact, expand both the scope of our work and the scope of your guys' work. This is our submissions. Thank you.
Thank you very much, Doctor, and thank you very much to all the people that have presented today. I have just seen that we have 5 minutes left. So as I said, you are happy to post your questions in the chat in the Q&A section. I see that some of those questions have already been answered. For those that are wondering whether this webinar recording will be available, yes, we will definitely be sharing the recording with you, so you can go through those slides again. But as you can see on this slide here, we do have some dissemination material available for you. So on the slide, you can download fact sheets, which are 2-page summaries of the key findings from both the quantitative and qualitative report by scanning those QR codes. The full qualitative report is also available by scanning the QR code in the bottom right-hand corner. And the quantitative report will be shared with all participants at this webinar via email towards the end of this week or early next week. So you'll have access to all the dissemination material from this webinar. So just in summary, what we discussed today was the TCDI Spot Check Prevalence Survey. We had a presentation from Dr. Terefe looking at the methodology employed. We then had Senzo highlighting some of the key quantitative findings. And for me, the key things that stand out there is that there's been a significant increase in the prevalence of tobacco and nicotine product use since the GATS report from 2021. So obviously we can't compare the national averages, but in the GATS report in 2021, we saw that the prevalence in KwaZulu-Natal was about 21%, and that has increased to about 31%. In the Western Cape, it's gone from about 32% to nearly 42%. So nearly 10 percentage point increases in both provinces. And another area of primary concern is the rapid increase in new and emerging products, particularly in the Western Cape, where we saw that e-cigarette prevalence was about 12%. So 1 in 8 people in the Western Cape using e-cigarettes. And if we narrow that down to the younger age groups, we see about 1 in 5 people are using those e-cigarettes. So something of public health concern there. We then, very importantly in the survey, didn't just do the quantitative findings, but as Dr. Veli highlighted, we did a qualitative analysis to see what is driving the trends we found here. And accessing that fact sheet and full report will give you a little bit more information about that. Just for time's sake, we won't have time for too many questions. As I said, the recording will be shared with you, but I'd just like to pose one question to Senzo and then one to Dr. Veli. So the first question quickly to Senzo is that, as I said, we've seen these big increases in prevalence since GATS, 10 percentage point increases in the Western Cape and KwaZulu-Natal. And then the question is, do you think that there will be similar prevalence increases in the other provinces? Because this was just a spot check survey. Senzo, are you able to respond to that question? Whether you think there's also been an increase in prevalence in the other provinces, not just KwaZulu-Natal and the Western Cape?
All right. Thank you so much. Thank you so much, Thomas, for that. That's a very important question. And our findings do show that there is higher prevalence sampled as compared to as GATS, as you've indicated, the GATS benchmark, especially for Western Cape and KwaZulu-Natal. However, for starters, I would be cautious in interpreting the results as a definite increase in the national survey, as on a national level, as we understand these were just based on the sentimental site areas of the 2 provinces. And secondly, with the 2 differences that happens between the 2 provinces, it's not to say that we expect the same if we look at the different provinces. So there are different type of conceptual explanations which are based on this observed patterns. So We should look at the different provinces with their own context and see if there is differences between what was published in earlier studies and what we can find. So it would be interesting to see other surveillances on the different provinces. So yeah.
Thank you very much, Senzo. So I see we only have 1 minute left. So Dr. Veli, you'll be excused from your question. But again, I just want to thank all the participants for joining today, particularly the members of the National and Provincial Departments of Health. We hope this has been a very insightful presentation for you. We have collected all the questions, and the ones that weren't answered here or in the chat, we will type answers and share them via email when we share that full quantitative report. So thank you all for attending today. We look forward to disseminating this information with you. Should you have any further questions, please feel free to reach out to me or other members of the TCDI or Moses Kotane research team. Thank you very much and enjoy the rest of your days.